Hello, I think we're live. Fantastic. Hello, everyone. My name's Helen Hughes. I'm Chief Exec of Patient Safety Learning, and we'll be introducing our speakers in a moment, but just welcome. We nearly had an extra sparrow in the room in Paul's house, so I hope everyone is bird-free and ready for a really, really interesting session. I'm going to just do a couple of quick thanks. One to Paul himself, because it was him and his colleagues at Philips that worked with Rob at GovConnect and myself that helped shape and design this session. So, and thank you hugely to the speakers who are going to contribute to that. And thank you to you for joining and in anticipation for the interesting and challenging questions that you're going to be asking of us. So you should all be able to see your chat functionality on the right-hand side of your screen. Please ask as many questions as you like during the presentations, and we're allowing at least 15 minutes for a Q&A discussion panel at the end. So let's start. Oh, the other thing is that there is an offers section, which is badly named because it's not a sales pitch, but there is content knowledge that people will be referring to that Rob at GovConnect will be posting in there. So you'll be able to take some of the content from today as we're being presented and hopefully have value and share that within your own organisations. So I'm going to start and I'm going to start with me and a little bit about the session, the aim of the day. Thank you, Rob. So do we have the right clinical guidance to deliver safe care during the pandemic? This is not a one-off question. This will be guiding us through the next months, possibly years, around our response to COVID-19. Next slide. So what have we learned so far? How are we sharing that learning? Is the guidance for healthcare workers being developed and updated? And that's something that any comments that you make in for staff members that are watching this, any perspectives that you have would be really helpful. And how do we ensure that our approaches support staff and enable patient safety? And I've got that little icon there which talks about what we're doing within patient safety learning, trying to have a safety stories campaign and enable people to share a bit of insight in those questions and more. So if you'd like to contribute, please do. Next slide. And the aims of the webinar. This was sent out, and obviously you're quite keen to participate because you're on the webinar. So we're going to explore some issues around staff roles, opportunities and barriers, and get a debate and gain insight from specialist expert leaders. And we've got a really fabulous speaker lineup for you to do that. And if we can then reflect on change and improvement that is needed, informed by your comments and questions, that would be great. Next slide. So teeny bit about us as Patient Safety Learning. You may have heard of us, you may not. We're an independent charity for patient safety and for system-wide change. We've been running for about 2 years now. And we say we aim to help people think differently about patient safety, more focused on action and improvement. And that's what today is all about. So next slide. And just a few reflections from where we are, because we absorb knowledge. People tell us things, we share that knowledge, and we share it through the hub, which I'll talk about later. But some personal reflections for us. Amazing commitment and response to COVID pandemic. Not easy always to find good practice, and we're going to be describing some of that, and Cheryl, particularly from her amazing work at the AHSNs, will talk a bit more. We see still huge cultural barriers to sharing insights between and within organisations, and some big challenges around equity and safety, and some groups being deprioritised and left behind. We've been working with some long COVID patient groups, really campaigning for their views and their needs to be met. And that was met only a couple of days ago, where Simon Stevens responded to some of the work with the patient groups and produced a 5-point action plan. So we've got some really good positive steps about meeting the needs of those patients. but we do have a huge backlog, and we'll have second wave pressures. So what's going on? How are we as a health and social care system meeting that need? And something that is very dear to our heart in patient safety learning, how are we doing that transparently with patients and communities so they understand the impact and the decisions they will make in terms of their own personal safety, but how they can access care and treatment. And for the others are going to be focusing much more on that. I'm just going to highlight a slide or two from the World Patient Safety Day initiative that was a couple of weeks back. And this year, the WHO, because of the pandemic and the impact on staff safety, they chose that global day was going to be talking about staff safety. So I'm just going to, next slide, please. I'm just going to talk about a little bit of why we have felt that staff safety is a patient safety issue. And many of you will be familiar about this, but I think the reflection from the work we've done and our collaboration with the World Health Organization and other parties internationally, as well as the UK, is that maybe there's been a separation of staff safety and patient safety, and actually they are two sides of the same coin. So we know that there are huge issues around physical safety, and Covid-19 and the response to it has really highlighted that, the risk of infection and harm to staff and patients, and the adequacy, or initially the inadequacy, of the supplies of PPE. Still, we're hearing significant challenges around safe staffing levels and avoiding burnout. That was with 50,000 nurse vacancies in the NHS. That was always a big issue, but has been exaggerated by the challenge of responding to the pandemic. And we know that overstretched and exhausted staff make mistakes. So we need to be responding to that in a safe systems way, not blaming and attributing the mistakes to individuals who are making genuine errors, but are we designing our systems and delivering our systems to minimize that error, and then supporting patients and staff should things go wrong. And the criticality of that is around psychological safety, of providing the environment for staff and patients, but in this regard for staff to be able to feel safe about speaking up for unsafe care where they see it, to identify opportunities for improvements from near misses or just good ideas, and to feel confident that they have an organisation that will support and respond to that, and challenge the blame and fear culture. And critical to that is the support to staff after patient safety incidents, whether there's been harm or otherwise. So on the right-hand side, I've got we did a series of interviews with frontline staff around that for World Patient Safety Day. You'll be able to see the links on the hub if you'd like to follow those up and contribute as we go through. Next slide. So I've mentioned the hub a couple of times. We had our first birthday last Friday. It's a free knowledge repository for patient safety. Since we went live with it, we've had our pages viewed just under 250,000 times, which is we're pretty pleased with that, given that we've got a zero marketing budget. But it's a place to share knowledge, to share opinions, to engage in debate, discussions, make challenges, and it's for everyone: clinicians, patients, patient safety experts, communities. So we would welcome your involvement, and the details will be posted up for you to see in sort of chat and in the offer. It's not our knowledge. We are kind of convening it for the benefit of others, and we know we've had tremendous support from a number of people, but particularly from Cheryl, the AHSNs and others, in contributing the knowledge and helping it share more broadly. Next slide. So you'll have this with a pack, but here are some contact details. Do engage with us, do share your knowledge, learn, but share your experiences for the benefit of others. Thank you. So I'm going to finish my talk now, and I'm going to hand over to Cheryl. And rather than me introduce everyone, people have had bios, but if you could just briefly introduce yourself as you go through, and we're going to go Cheryl, Claire, Paul, and Matthew, and then the Q&A at the end. So Cheryl, over to you.
Thank you, Helen. Cheryl Cox, the Academic Health Science Network Patient Safety Director. I've got an echo on my voice. I don't know if that's the same for everyone else. I hope not. Let's go. So
I'm going to turn my audio off, and I think if the other presenters could do that, that might help. Let's have a go.
So I'm going to take you through a few slides. That's much improved, thank you, which talks about the learning and the reprioritisation that we've undertaken as a result of the COVID pandemic. So in response to the NHS Patient Safety Strategy, the Patient Safety Collaboratives, which are part of the Academic Health Science Network across England, have a programme called the National Patient Safety Improvement Programmes, commissioned by NHSE and NHS Improvement. And we have responded as an AHSN network to the NHS Patient Safety Strategy. Next slide, please. By creating a vision of our own, which is to support the delivery of the strategy and for us to be aligned for the NHS to continuously improve patient safety. So I want to give you a few examples of how we've been doing that. Next slide, please. So first of all, how we've responded to COVID-19. So our Patient Safety Collaboratives work was rapidly redirected to focus on areas that were relevant to the system in relation to the COVID pandemic. So we were able to focus on identifying and managing people at risk of deterioration, implementing a new programme called the Safer Tracheostomy Care Programme, supporting maternity and neonatal units and safeguarding mothers and their newborns, gathering intelligence at local and feeding up to the centre, and developing a SITREP, which was a tool to collect all the information across the system and help us theme that and respond to that. And the next few slides are going to tell you a little bit about that in detail. Next slide, thank you. This is just a timeline of our responses. You can see that the pandemic came in March. We were rapidly able to reprioritise our work, introducing a new programme of work and focusing on supporting staff either through joint webinars or the availability of resources, signposting, or developing how-to guides. Thank you. Next slide. We were able to capture our learning and the intelligence both from local and system levels through our SITREP tracker, but we were able to identify 4 broad themes. So tackling patient safety concerns, change in normal workplace processes, digital opportunities and challenges, and supporting the workforce. So building on Helen's point about this is not just about patients, but it's about supporting staff to deliver safe care in challenging circumstances. Next slide, please. So this is an example of our SITREP tracker and how it's presented. It's an online and continuous virtual tool. It breaks things down, all the intelligence we feed into it, into themes. So you can see for maternity and neonatal, the theme around safety issues was the greatest theme recorded. And an example of that would be that we understood locally that mothers, pregnant ladies were not attending hospital in a timely way because they were frightened of going to hospital at this time and were coming to some harm. We were able to feed that up to the system, and that was developed into safety netting leaflets for mothers, also through the local systems to support mothers through their midwifery services to seek help at appropriate time. In terms of medicine safety, this focused on 2 areas, one around care homes and the provision of end-of-life drugs, and secondly around anticoagulation for patients in the community. So those patients who were on warfarin, who would need regular blood taking and dosing schedules, which wasn't going to be possible during the pandemic, were switched to an alternative anticoagulant drug. And what we found was that some patients were inadvertently being put on 2 anticoagulants, so we were able to rectify that, or the new anticoagulant they were put on wasn't the right dose according to their renal function. So we were able to highlight those issues through our networks right up to the centre, and these were addressed immediately. Next slide, please. This is the National Tracheostomy Programme. There are 15 interventions in there, brand new programme for us, and because of the rapid rollout that was required, we chose 3 safety interventions that would make the biggest impact. We realised this was an important programme because of the number of patients that were being admitted to intensive care. We understood that they were likely to have a tracheostomy put in place, and would be transferred towards with staff who are unfamiliar about how to look after patients with tracheostomies. And this provides, very unsafe space for both staff and patients. So we were able to mobilise virtually 3 safety interventions, which was about bedhead signs with an emergency algorithm should anything go wrong, emergency equipment, and a daily care bundle. And as you can see from that, in the first quarter, we got 85% penetration. 164 out of 192 eligible sites had adopted all 3 safety interventions at speed. We were able to support that with regular conversations virtually, follow-up telephone calls, and a how-to guide. Thank you. Next slide. In terms of managing physical deterioration, we were supporting the development of virtual wards. The original 11 pilots that were supported by the NHS England and Improvement, there's now over 30 of those, and they're spreading widely. And they're looking after patients in the community with pulse oximetry and a pathway of care for escalation. We were supporting News 2 and Restore 2, which are deterioration tools, and we also mapped the number of digital applications that were currently out there to support and manage deterioration. And we've now been able to spread out of 12 of the 15 patient safety collaboratives, the tool Restore 2, which is being used widely in out-of-hospital settings. Next slide, please. Safety in care homes is a real priority for us for lots of reasons, but we were able to support them with a News 2 or Restore 2 tools, and we've been able to spread that widely. And a suite of e-learning resources, because we couldn't deliver face-to-face training, we were able to use and repurpose some of the e-materials that we had already jointly designed with Health Education England. And we've had over 40,000 views on YouTube of those e-learning modules. Next slide, please. Again, we've supported primary care. We did a joint collaboration with the Royal College of GPs. We've run a series of webinars now supporting primary care clinicians to understand the COVID pathology and how to use news in a very challenging situation, and the use of pulse oximetry. And that's been really successful, and we continue to work with the Royal College of GPs for future webinars. Next slide, please. Again, supporting and implementing digital solutions. This is just one example from Manchester called Safe Steps. Safe Steps was a tool that was already in development in Manchester to support reduction of falls in care homes, but were able to work with the company to develop a COVID app, which identifies residents in care homes who have symptoms and alert appropriate agencies and the right response. And in the pilot, health and care teams supported the health of more than 1,300 residents across 40 care homes. Thank you. Next slide. And again, in focusing on staff, we have an Only Human campaign in London. There are a number of other psychological safety tools in use across the PSCs that have been used to support staff. This campaign takes a peer-to-peer approach, supporting staff in the workplace. Thank you. Next slide. So what have we contributed? Well, what we do well is that we already have locally developed networks, and we're able to use those to great effect. We were able to change from face-to-face meetings to remote working very rapidly, able to reprioritise our work programmes to make our programmes relevant to the system and respond to Covid-19. We were able to connect people both at organisational level and at system level. We were able to share learning resources and insights, and we've made sure that our future programmes are now sustainable. Next slide, please. And these are our future programmes, probably too small for you to see, but there is a new programme around mental health, and that's been reprioritised to take into consideration the priorities that have emerged during COVID. And suicide prevention and self-harm is one of the huge priorities now, and that affects both patients in hospital but also staff, where we've seen an increase in suicide risk there. And we are starting to remobilise those programmes. They are all still relevant in the COVID pandemic. We're starting those now for the next 18 months, should COVID not get in the way too much. Next slide, please. And focusing on that are 8 key enablers. And what's really important about that is that patients and carers are involved in the co-design and co-production of this work. And we're also addressing inequalities in both ethnicity, race, gender, etc., to take into account all the issues raised by COVID to date. Next slide, please. And I'm going to finish on the last 2 slides talking a little bit about virtual wards, because they are just so relevant at the moment. We are expecting these to be rolled out nationally. The COVID virtual ward is about looking after patients in their own homes, wherever they may be, in order to safeguard them, to monitor them on a daily basis, and to escalate them to appropriate care when the time is right. We offer support through a learning network, a national learning network, which brings all the pilots together and anybody who's wishing to start a pilot, so that we can share ideas, knowledge, and information. We have a repository of information on NHS futures, so people don't have to reinvent the wheel, and it allows a chat opportunity so that people can make contact. And we've also got our local networks through our deterioration and care homes networks to support local work. Next slide, please. So we're hoping that through a national rollout, we'll continue to work and support our local systems. And should that decision be made centrally next week, we're hoping to work locally with our CCGs. We will offer QI support and expertise. We'll help set up and run these through webinars and responsive roadshows. We've also got safety netting leaflets for people in their own homes and for carers, and we'll support and develop training materials and how-to guides. Thank you. Next slide. So that finishes my set of slides, and this slide is just to give you more information should you wish to make contact, either with myself or one of the 15 local collaboratives. Thank you. You're on mute, Helen.
Still unmute. Sorry, a really impressive list of initiatives. We've got so many people that have joined us. It's really welcome to have you all. Please do submit your questions. Do you know about those initiatives? Are there other guidelines you need? And keep the questions coming. I'm going to pass now to Claire. And Claire, you introduce yourself, please. And you're on mute as well, so it's not just me. Claire, you need to unmute yourself. Claire, you need to. I think she's struggling to get. Oh, that's better. We can hear you now.
Sorry, Hugh.
Yes, that's great. That's good.
There I am. Okay. Thanks, Helen. Hello, everyone. Thanks to so many of you for joining us this afternoon. I am here in a very wild and windy northwest of England, and I just hope that my connection lasts for the next hour or so. So I'm Claire Wade. I'm from the Royal College of Physicians, and I'm the head of patient safety there. And I'm here this afternoon to share with you all what is available on the RCP website to help you all, hopefully, in relation to COVID-19, and also to share a few thoughts in relation to learning from the past few months. So, from the very beginning of the COVID pandemic, the RCP recognised the need to support our members and the wider healthcare teams that they work with. We knew that there had already been a lot of learning and sharing of lessons from countries that were ahead of us with the virus, such as Italy. But we immediately wanted to engage with our members. So we undertook a number of surveys, and we asked our clinicians to tell us what it was for them, how it was for them out on the front line in the COVID pandemic. And the really rich data that we got back helped us to write guidance, and we collaborated with many other people to write documents to influence government and the Department of Health around the really serious areas such as PPE. So on the RCP website, and hopefully there is a link that is showing for you now in offers, we have a specific RCP and COVID-19 area. Next slide, please, Rob. So, excuse me, sorry. Anyone can access both the website and the COVID area, and the content is all free of charge. Next slide, please, Rob. So I'm just going to spend a little bit of time going through what you might find on the website, and hopefully what is going to be useful for you all. So firstly, the RCP player. It's an excellent resource. It has its own specific COVID response area, and this includes some doctors' diaries. They are very short videos sent to us by clinicians on the front line. We also have some guides to research and learning during COVID-19 in the RCP player. So, as well as the RCP player, we also have other publications, including the COVID-19 safety advice, learning and development during COVID-19, and some guidance for trusts supporting returning clinicians to the NHS. Now, you might feel that we are a little bit beyond that, but actually, as we feel that we're heading into what is possibly a second wave, particularly up here in the north of the country, this might be a really good time to have a look at documents like that and hopefully prepare for what might be coming. Next slide, please, Rob. Thank you. So I've already briefly touched on the surveys that we've carried out, and we also asked some questions on the impact of COVID-19 on the workforce. And the answers to these questions helped us to produce some guidance around priorities for future COVID-19 planning, and also the resetting of outpatient services in the context of COVID-19. Next slide, please, Rob. We also collaborated with many organisations, societies and specialties, and on the RCP COVID page we have many links to a number of specialty plans, including some for allergy services and palliative care. The patient safety team also produced some additional guidance for clinicians using News 2 with COVID patients. And the college also did a piece on COVID-19 and mitigating the impact on health inequalities. So please do take a look, spend some time on the RCP website, and I hope that you'll find some really useful resources there. Next slide, please, Rob. So on to the second part of my presentation. We knew at the early stages of the pandemic that healthcare would really need to change and adapt quickly to respond to the challenges that were ahead. And it was really great to witness the innovations and improvements, such as the rapid and increased use of virtual appointments. Many clinicians reported experiencing fewer barriers to change. Next slide, please, Rob. But we really need to reflect and understand these rapid changes. We need to be sure that they are good and positive and not just make assumptions. So if we go back to the virtual and telephone appointments for patients, I'm sure I was one of many who really found that a very positive experience, but there will have been patients out there that struggled to engage with that kind of appointment, whether they struggled with IT and technology, or some reported actually not liking having their consultations at home. It didn't feel formal enough. They didn't feel able to ask questions of the healthcare professionals that they were engaging with. So we really just need to make sure that what we are implementing serves the patients that we that we look after. We also need to make sure that we don't return to those former practices and those barriers that we talked about earlier. We need to incorporate staff care into our learning and future plans. Many staff over the last few months have reported burnout and also mental health issues and challenges. And it's been really interesting in recent weeks to speak to some clinicians who are in those frontline services and who are starting to receive patients again with COVID-19. And some of them report almost feeling like a flashback scenario and feeling anxiety around the fact that this is starting to happen again. So we really need to make sure throughout the NHS that we've got processes and structures in place to support staff. We also need to ensure that the patient and public voice is really included, and not just as a tick box exercise, but to include them as real collaborative partners. As I've already said, we might think that practices that we've introduced are great, but they might not be right for the patients, and they have to be, because they're the people who we're all here to look after. Next slide, please, Rob. So that's it from me. Thank you very much for your attention. They are my contact details, so my email address, and that's me on Twitter and LinkedIn. Please keep in touch, and I look forward to your questions later on in the session. Thank you. Thanks, Helen.
Fantastic. Can you hear me? Have I switched it back on properly? Yep. Can someone do a thumbs up if you can hear me? Oh, yeah, great, thank you. And fantastic, thanks, Claire. And lots of rich resource there. Questions to Claire as we're about to go to Paul, but I see from the Q&As lots of interesting questions. And thank you so much, Cheryl. You've been answering them, and particularly even the question that I asked, which was a bit cheeky of me, but lots of interest in the virtual ward. And I've been marking some of the questions we might come back to if we have time. So thank you. Keep those questions coming. And I'm going to hand over to Paul now.
Lovely. Thank you, Helen. So good afternoon, everyone. Thank you very much for your time coming to join us on the webinar today. My background, to give you a little bit of understanding where I'm coming from, is just under 30 years as a critical care nurse within the NHS in various specialities. In the latter years, cardiac surgery specialist. I then joined Philips Healthcare as an application specialist about 8 years ago, and now have the privilege of managing their clinical services across connected care. So an innovations company that supplies health technology to the health sector across the globe. But what I'd like to do today is share some of our insights and experiences from a medical device perspective, a little bit before COVID, but and then how COVID has changed that and sort of turned things on its head a little bit. So Rob, next slide, please, if you could. Sort of pre-COVID, we were very driven by regulations within all global markets, but in the UK, the MHRA recommendations are very detailed and very specific. We also have CE markings. FDA approval is required for all of our devices that go into the health sector, and I'm really pleased about that. It means that strong regulation provides patient safety, provides detailed analysis of equipment function, etc. But one of the things that we were very aware of is that there are recommendations for training on medical devices, and that's where my role comes in within the company. Is that my team makes sure that the clinical staff receive training on the devices that are put in. So if we look at the context of COVID-19, that's patient monitors and patient ventilators, both in the non-invasive and the invasive areas. And what we were aware of pre-COVID is that the requirement was to provide training. We were delivering training in an environment that was resource poor. Poor numbers of staff, very difficult to get all staff together out of the clinical area. So traditionally, training was delivered within the clinical area, grabbing hold of staff as and when we could, to give that device training. So it very, very quickly became a buttonology exercise, teaching staff how to actually use that equipment. The education then was very focused on the technical side rather than on the clinical, making sure that we delivered the information that regulators require to enable staff to use the equipment properly and use it safely. So next slide, please, Rob. But one of the things that we've been aware of for many years is that there is a technology bear trap, that technology has made us able to do an awful lot more and therefore reduce resources that we require. But perhaps we don't need to understand as much about what we're actually doing. So by putting those human skills that we use within the health sector into black boxes, and the example I've quoted here is that we've got many machines out there in the market that enable people to take blood pressures, but it actually removes the skill of actually being able to take a manual blood pressure. So we're putting the expertise into the machine, because that lowers those barriers for entry. Many more people can do that task, but we ultimately become very, very reliant on that technology. And that's a very simplistic example, but if you expand that through across sort of like a large portfolio of medical equipment that we use these days, from, as I've mentioned already, patient monitors, ventilators, CT scanners, MRI scanners, that technology bear trap is there that we have to be aware of. So next slide, please, Rob. So my team pre-COVID would spend a lot of time tracking down as many staff as possible in agreement with a customer and the clinicians on the shop floor, doing our very best to deliver the required training to those staff. But COVID-19 turned our way of working on its head as medical device trainers, if you like, because we no longer had that traditional face-to-face access. It wasn't safe for us to go into clinical environments, either for ourselves or to protect, patients and staff from, contamination from us. So we had to develop different ways of working, and we did that very quickly within Philips, but also across the industry, to enable us to do what we're doing today, is to deliver communication and information on a virtual platform. But one of the things that we did find when we started doing remote training is that we actually got the attention of clinical staff for longer periods of time, because they had to be removed from the clinical environment to go into a virtual environment. And what started to become apparent very, very quickly was that the level of understanding that the clinical teams had was far different than what we would expect when we were going in to do technical training. So when we first did training, sort of pre-COVID, that face-to-face, you were delivering under some assumptions. But when we've had the ability to spend more time with our clinicians, and I'm talking about clinicians across the board, from healthcare assistants through to consultants, their depth of understanding about the function and the application of this technology was lacking in quite a few areas. So next slide, please, Rob. So following on from the challenge that was issued by the Department of Health, industry mounted a huge response to support COVID. And if we just look and just pause a little bit to see the level of change that went on just from an equipment point of view, that over the last 6 months since COVID's hit the UK, there's been 7 years almost worth of sales, ordered, manufactured and delivered. Over 15,500 patient monitors, £100 million worth of kit, over 1,000% increase in ventilators delivered into the market, again around 86 million. So a huge amount of equipment was actually been delivered into that environment. Next slide, please, Rob. So huge response from industry to support Department of Health and clinical aims. And from a logistics point of view, the system that was been set up is multiple manufacturers in response to those challenges were delivering equipment to a central Department of Health warehouse structure. And then the Department of Health then and now are using a push model to deliver the equipment needed to those specific clinical sites that are requiring them. And I should imagine at the moment there's quite a bit of equipment being delivered to the hotspots within the country, sort of to the northeast and the northwest and sort of North Midlands. But along with that huge volume of equipment that's being delivered, comes a training requirement. Just because we're in a global pandemic doesn't mean to say we shouldn't be delivering that training. In fact, it's more important. So if we couple those factors together, that we've had a huge increase in the delivery of equipment, going into clinical environments that are poorly resourced, under huge amount of pressure, increased difficulties in delivering training, and then we find that those people we're delivering training to, in actual fact, the knowledge that they had, we assumed they had, is there's a deficit there. And I'm sure you're all aware from multiple news articles that there was a lot of staff drafted in to high acuity areas from outpatients, from other areas outside of industry as volunteers. The airline business sent a lot of staff in to help with hands-on care, etc. So we almost created a perfect storm in terms of risk to patient safety. Next slide, please. So just a quick recap before we move on. So COVID has taught us that we need to have new ways of thinking about how we support clinical staff in using the technology that's there. The technology is really important because our ways of working within high-tech environments require that equipment, and we don't have sufficient staffing resources to do it all manually. So there has to be a balance between the two. So that education and training landscape for medical devices will now have changed forever, and we need to respond to that. And trainers will also not only need to be skilled in face-to-face education, but they'll need to be skilled in using those remote technologies to deliver content. We must take care to make sure that the customer engagement is maintained during those dialogues. If anybody's done any level of education, if you're working face-to-face with someone, you can see if their eyes start to glaze over or they start yawning, that you've lost their attention. One of the advantages of virtual training is you don't get that. So if anybody's yawning at the moment, I'm not getting stressed by that because I can't see it. So we have to make greater effort to keep people engaged, and leverage those leveraging those digital platforms that are now available is key. The key factor I want to just mention before we move on to the last part of my slides is that attendance shouldn't be the measure of whether somebody's had access to that training or education. The outcome, the learning outcomes to me should be the most important factor. And pre-pandemic, we perhaps didn't pay as much attention to that as we should. So next slide, please, Rob. Okay, so just before we move on, just to recap, there is a fundamental difference between training and education. And this is the point that I really want to labour, that has been really highlighted within COVID-19, that there's a huge amount of training goes on, delivered internally and by third-party industry partners to clinicians on the front line. But training is that action of teaching a person or a group a particular skill or methodology to enable them to do a specific task, how to turn the ventilator on, how to put the settings on it. But what training doesn't do, and has been, and training has been the main form of delivery of that information, it doesn't allow empowerment of staff. It doesn't give them a flexible approach to achieve a level of competency and understanding and enable them to apply that evidence across different pieces of equipment. If you like, my dream or my passion would be that, clinical staff are educated to a level that a ventilator just becomes like another car. You might have a Ford today, but if you go and buy a Peugeot tomorrow, you can still drive it safely because you understand about road etiquette, road safety, you understand how the car controls work. So we need to switch our focus from training to education if we're going to make a real difference to patient outcomes and to safety, so that people not only understand how to operate the equipment, but also are empowered to understand its function. So next slide, please, Rob. So I'm going to be a little bit contentious here. I mean, perhaps get rid of some of the glazing if it is going on there. One of the examples I would put forward to is, and a question I'd ask all the panel, as well as anybody that's on the webinar today, is as an example of my challenge to change training into an education delivery is, should we train people to resuscitate cardiac arrests, or should we educate people to prevent them happening in the first place? So if we look at some of the figures then, so our UK National Cardiac Arrest database shows that there's actually a pretty poor survival from in-hospital cardiac arrest. It's only 18.4%. So there's a huge impact on patients' mortality and morbidity as well. We also know that despite huge investment of cardiac arrest training across all walks of life within acute healthcare settings, that 98% of non-nursing or medical staff never get to use those basic life skills in their whole career. But yet we've put this huge investment in training them. And 50% of nursing and medical staff who have had training in their whole career actually never even witness a cardiac arrest. But those that do attend them, their median attendance is only probably about once a year. So the training that they receive is detailed, rigorous, gives them skills to perform a specific task. But perhaps, the incidence of cardiac arrest, which comes out at about 88 per general hospital in the UK per year, maybe I would challenge you to say we should be focusing our resources and training and education skills in a slightly different direction. Next slide, please, Rob. As I said, I'm being a little bit contentious by putting that out, and I know there will be a pushback to say we must be able to resuscitate patients. We never know when it's going to happen. If it does happen unexpectedly, anybody that's around in a healthcare setting should have those skills to resuscitate. It's a patient safety issue. Ignaz Semmelweis, back in the 1800s, actually put forward a very simple proposal. He was a physician then, working amongst his peers, and he challenged them to wash their hands more regularly. Okay, because he saw a very high incidence of purpura in post-delivery patients. After the pregnant ladies deliver their babies, they're getting lots of infection. So his mantra was wash your hands, and he made such a fuss about it and challenged the beliefs of all of his peers to such an extent that they actually put him into an asylum in the end. Okay, so it's now been known, sort of dubbed the Semmelweis reflex, is that tendency that we have to reject new evidence or knowledge because it really contradicts what we do. And I would like to see one of the outcomes from COVID-19 is us get rid of the Semmelweis reflex and actually understand those changes that we can initiate on the back of the huge impact that this horrible disease and illness has had. So next slide, please, Rob. So if we changed our ways and changed our approach and put in, from industry, if you like, device vendor neutral, so it doesn't matter, what piece of equipment it is there, the education program that's put in to supplement the training is aimed at educating staff in the broader principles of using that technology. So they not only learn the skills to operate that equipment, but they really understand the reasoning behind it. And just because we're not working on the front line doesn't mean other people don't hold expertise. There's a huge amount of research and development goes in across the world from industry and technology companies. And the aim of that is to make a real difference to patient safety and improve outcomes. And my strong belief is that if we add in education to training in partnership with healthcare providers, industry can really optimize the use of that and the function of that technology and make a massive impact on patient safety. So next slide, please. So this is the proof of the pudding. So a hospital in North Wales had a new set of equipment put in, automated early warning system that gathers the information automatically from that equipment that takes the vital signs, puts it in through an algorithm and gives an early warning score. Couple that up with a very focused education program for the staff to alert them to those signs and symptoms that are usually prevalent 6 to 8 hours before a cardiac arrest. And these are the results that we can show. So a 35% reduction in serious events, an 86% reduction in cardiac arrests. To me, as somebody who's worked in a clinical environment, that's a stunning piece of evidence. A 24% reduction in ICU admission rate from those patients that are already in hospital. And surely that's a really salient point in these times when we know that ICUs are coming back under pressure again. And of those patients that were still admitted to ITU, we found that there was a 66% reduction in their mortality, because when they arrived in the ITU, they'd already had treatments initiated and started. So they weren't falling off the cliff edge. They weren't as sick when they got in there. So again, that just sort of bringing my brief presentation to an end is that COVID-19 has taught us or reinforced to us something that we were starting to see already, is that training and instructions for use are not sufficient to maintain patient safety. When we look at the huge amount of technology that is present now and is coming just around the corner. So we really need to take a step back, look at how we educate people to enable them to have the knowledge and skills and the understanding to actually leverage the equipment that innovation companies are putting in there. Thank you very much for your time. That's just passing back there, Helen.
Thank you. Can you thumbs up if you can hear me? Great. This is to Matthew. This is so good, but we're running out of time. So we've already, if those of you on the panel and also participants, if you're able to stay for another 10, 15 minutes at the end of the, thank you, Claire, at the end of the session, then we'll have a chance to, because some of the questions have been fantastic. And so we do need some time for that. So no pressure, Matthew, about keeping to time. And in terms of your role and kind of behavioural insights, very, very interesting what Paul said about Semmelweis and how obviously that affected the whole kind of idea of behavioural change for improvement. So I'm going to pass to you. Please keep to time, and then we will have time for Q&A after.
Hey, thank you very much. Hope you can all hear me okay. And yes, I think my team live the pain of Semmelweis on a daily basis. I don't think any of us have been sectioned yet, but I suppose there's always time to repeat that. And yeah, I mean, what he recognised and observed is par for the course in the way the human mind works. So a nice segue in. We don't work in patient safety. We work across the whole remit of NHS England, and the behaviour change unit came into being in response to COVID. The work we've been doing, we've always done under other guises. So before COVID, we were called the Sustainable Healthcare Team, and before that, we set up and ran the Right Care programme, which still runs, but other people lead that now. And the stuff I'm going to touch on in the next slide is the types of insight, expertise and thinking that we try and put into the work that we do and others. So during COVID, our function has been to support everybody else in building their responses and trying to enhance their impact via the 4 pillars we use. And since March, when we set up, we've done, I think it's now, it goes up every day, but we've done 180 different projects, some big, some small, and always in support of someone else. Many of them were indirectly in support of patient safety, and a few of them were directly with the patient safety team or the IPC team or PHE, and often all together. So we're not patient safety experts. We're if our expertise such that is trying to help other people have more impact through their work. So next slide, please, Rob. So just very briefly, this is essentially what we do and how we do it. We have 4 pillars. One of them is traditionally involved in NHS England and regional and frontline thinking. Although we would argue not as much as it should be and not as often in each pathway or project as it should be, and that's clinical insight. So whilst we aren't the only providers of clinical insight in NHS England, we have a clinical team so that where other people aren't able to get that insight or aren't able to get it as readily, or aren't able to get it with a behavioural science, process engineering and a knowledge management nuance, then we provide that. So our clinicians are often involved, but sometimes other people's clinicians involved. The concept is that whatever we do in the NHS, whether it's beginning to think about building a policy at national level, or working out how to transform a clinical pathway on the front line, or how to run an estates function or enhance an estates function, that clinical insight should always be involved from inception, to ensure that even if it's not a clinical issue that's being dealt with, it accounts for the clinical need, and so it's built as well as possible to hopefully facilitate and enable better clinical delivery on the front line and patient safety within that, and if not, at the very least, not become a barrier or an obstacle to optimal clinical care. The other pillars that we try to help other teams with are the behavioural science, the behavioural insights, and we have 4 or 5 partners that provide behavioural science into the mix, and accounting for things like the Semmelweis reflex. Knowledge management on the basis of the fact that no one can possibly know everything that they need to know to make a choice or a decision, and if we recognise that at the beginning of our thinking there's more to know, and we send knowledge managers out there in a metaphorical sense to find all the evidence and knowledge that is out there, so that we can gain more knowledge before we then use that to try and tackle the big problems that we're all trying to tackle. And the 4th pillar is process engineering, and I think that one in particular has played a very significant role in how we've responded to the pandemic nationally, and that goes into how we make choices in times of crisis, how we make decisions, because it's proven by behavioural scientists beyond any doubt that when we go into crisis management, our ability to make right decisions plummets, and that happens to all of us. And the reason for that is we are no longer able to use, there's 2 types of thinking that our brains use when it's making choices or decisions, and that's fast thinking and slow or considered thinking. In organisational contexts or scenarios, virtually always considered thinking is the best way to come to a right decision, so you can think things through, and things like options appraisals and so on, that's all part of how you then have the process of considering. When you go into crisis management, you haven't got time for that, because you're making 1,000 decisions a day, and no one else has got time to put together the case for you anyway. And so as a result, we have to revert to only using our fast thinking, which has many flaws in it. And the Semmelweis reflex, or the flaws that he observed, are the flaws of fast thinking used in the wrong scenario. So you want to use fast thinking when a child steps out in front of your car. You don't want to consider, should I brake now? You just want to instinctively brake. But when you're going, how do we build a model that allows regions to build Nightingale wards, and staff who come into the Nightingale wards to know how to do what they need to do in the new environment. For those types of things, you want to use considered thinking, but you can't, because you haven't got time. The use of process engineering partially mitigates that and reduces how much your decision making plummets, and as a result, we've been very busy helping lots of teams think about how they process their decision making in crisis and so on. It also has a big part in removing ambiguity from guidance, simplifying guidance that's written in word form into infographic form and so on, to try and make the message more easily received and without the risk of misinterpretation by, for example, staff on the front line or the public. So I'll just whiz through a few examples to try and give that some context. So the next slide, please, Rob. This is one of the very first things we did as part of the response. The rest, not so much the rest of the post, so that was done collectively with PHE and various others, but that bit at the bottom right-hand corner, and the power of 4 words, if you build those words from a behavioural perspective. I think the protect theme is still there. It's not as common as, it's not now in front of Boris Johnson and co when they're doing their things, but it was, and it's also on a lot of things. But the reason that we came up with protect yourself and others right at the beginning, that then turned into that theme, was because it triggers the two things that motivate us as humans to behave in a particular way, in this context, to comply with a public health message. And that's altruism and rational egoism. So altruism is doing something because it's for the greater good and because it helps others. And that's a really big motivator for many of us. But so too is rational egoism, which is doing the right thing because it feels good to do the right thing. And that's a more egocentric reason for choosing to comply with the pandemic messages. So the four words, protect yourself, that triggers rational egoism, and protect others, that triggers altruism. But by combining them, you get a third benefit, which is essentially your mind doesn't know you're doing this, but we're all going, hang on a minute, so I can pat myself on the back for being selfish and looking after myself. And that was why it had such an impact. That's why it became a theme. So very simple things like that, and there's obviously a lot more complicated stuff that behavioural scientists and process engineers do, but that's one example that can have a big, powerful impact, including in the patient safety world. Next slide, please. So these are a couple of slides that have recently been published, partly from the lessons learned of the first wave, and what in that spike when we were doing 1,000 things a day, but you needed to do 3,000 things a day if you wanted to keep on top of all of the vital things that needed doing, but we just couldn't. What were the next most important things that we didn't get around to that we couldn't do for the second wave? And this is one. It also has a big role to play in staff well-being and removing that anxiety and so on. This is the office version, and then because obviously lots of us work in offices. And then the next slide, please. This is the frontline version. So how to feel this, the implicit reason for these is how to feel less anxious by being safe and knowing that you can have some control over reducing your risk when you're on the front line, and so on. So use of infographics, behaviourally proven to be more readily received by the human mind, and so on, and just 2 or 3 key messages so that you can contain those things and keep repeating them to be consistently safer than you would have been before. So next slide, please. I won't go through these for time, and also that's very fortuitous for me because these are the slides from the patient safety team, so you'll probably very quickly recognise that I'm reading other people's words out and not necessarily knowing what they mean themselves. So we're sharing the slides so you can all have those and see some of the stuff that the patient safety team have been doing, much of which I'm sure you're aware of anyway. Next slide, please. And there's a mention of virtual wards there as well, which has come up, hasn't it? More of the same. And there's an email at the end to my team that if you want to know more about any of these, if you come through us, then we'll pass you on to the patient safety team. Next slide, please. This is my final slide. Like I said, we've done 180 and counting things during the pandemic. That's just a list of some of the ones which are directly and indirectly supporting the safety agenda. Staff safety has been mentioned a lot. That's not on this list, but we've also done a huge amount of work on well-being within the workforce and so on. And if you'd like to contact us, either because you'd like more information or because we are an open to everyone's ideas team, where we don't assume that we're the only ones who have good ideas, we assume that we're the least likely to have good ideas and everyone else out there in the system is more likely to. If you think we need to work on something, then if you email that address and tell us, then we will use our process engineering techniques to check that yes, that's something within our remit that we can add value to, and by virtue of our remit we will then try and help and get back in contact with you accordingly. Okay, thank you.
That was fantastic. Thank you. Can you do a thumbs up if you can hear me, everyone? Ah, great. Yeah, and a nice alignment back to Cheryl's first sort of introductory talk. So many questions. We'll carry on going until Rob lets me know that we've run out of time. People have fed back how much they've enjoyed today's session. Some have had to go because there's a 2 o'clock deadline for getting off to another meeting, and we've got far too many questions. I think one of the reflections there most recently from Helen Courtney is about, would be really good to hear about patient safety in the time of coronavirus with mental health and learning disability services. We have predominantly, as often is the way with patient safety, talked very much from a hospital and acute hospital perspective. So, you know, if we can facilitate other events that will focus more on that, we can. So apologies, it's been more acute focused today. Cheryl, I think huge amount of interest on virtual wards here and wanting to know more about them. How will people find out about that?
Yes, so there's a link on my slide.
Oh, you're on mute.
Oh, am I still? Sorry. Can you hear me now? Because I'm pressing the button.
Oh, yeah, it's just
yeah. Okay.
Yeah,
there's a link on my, there's a link on my slides. You can find out more information from our website. But if you want to email me directly, I'll make sure you're on the list for the virtual ward learning network that we run every 2 weeks.
Yeah, that would be fantastic. And I think what Rob and the GovConnect team will do is make sure everyone that's on the call gets the full recording and the resources. And I've mentioned in the chat room a couple of times, we'll collate those and put those on the hub. So that's another way of getting them out there. I'd like to ask the question or the comment that Rumer Kinnaid Weeks makes about the patient voice perspective. And Rumer mentions about the need for discharge summaries to be properly documented so that patients know what should be expected. The link between inpatient and community is not always as seamless as possible. People are not always chasing up information and follow-up appointments, investigations, because we know it's COVID. And Rumer feels that there's a lot of serious long-term conditions and care that has fallen between the gaps. I don't know if there's any work specifically on that or any comments people would like to make in response to Rumer. I think it's a very valid point. Yeah.
So we always try and, well, actually, our fifth unofficial pillar, because we don't have them employed within the team, is patient insight. And obviously, the pace at which we're working makes that slightly harder to do as well as we'd like and hopefully do in normal times. But yeah, we're linked in. We have partners, as well as 180 projects. We have 140 partners, and given we had 0 at the beginning of March, we didn't exist. You can see how hopefully that demonstrates whenever we do something. One of our within our process engineering, there's a step that you cannot get past until you've which is, who else should we have around this table who knows more than we do? And patient voice is always on that list.
Thank you. Mike Eccles mentions lots of patient concerns about telephone access and the unfriendliness of e-consult. And that's something, Claire, you picked up about needing to respond to the needs of patients, and not everyone was as positive about the opportunity to get virtual access. I mean, what's your view about what is needed to capture that and to design that into future services?
Yeah, thanks, Helen. I saw that question as well. It is tricky. It is difficult for a lot of people. The thought of not sitting face to face with your clinician or nurse is a very new one, and often the virtual solutions can feel very impersonal. So I think that is something that we need to work on as a healthcare sort of collective. I think it's very important to get feedback from patients who are using it. Do they like it? Do they not? Why do they not like it? And also, what do they think would make it better? What would make it easier for them to use or more palatable? We're very good in healthcare at thinking that we know what the patients need or what they would like to have, and actually that's not always the case. So I think we need to engage at different levels with different patient groups. Often at the minute with the virtual solutions, it's the elderly patients that find it challenging. You know, we all know children who from the very early ages pick IT things up and just seem to know how to work them and feel very comfortable with them. So I do think we need to engage at all levels, at all different kinds of interactions. You know, some interactions are very informal and very quick. It might be a medication review, and then other people are having virtual consultations for very much more serious conditions, and we need to understand across the breadth of what's happening and tailor as far as we can to what patients need.
Thank you, Claire. I was just wondering, Cheryl and Matthew, you're probably more likely to know than myself and Paul. Is that work being picked up anywhere, do you think?
Yeah, so in terms of working with patients, carers, service users, I know there are national groups, there are also regional and local groups, and we have as one of our key enablers the co-production and co-design of our programs with patient public groups.
And is well, yeah. So I'm just trying to think how we get all these questions in. Any specific question that the colleagues have seen that you'd like to answer? Because I'm sort of hogging it, but that, I suppose that's what chairs do. But any specific ones that you saw that you want to respond to directly? If not, I'll carry on. But Matthew, was there something you?
Yeah, so I not a necessarily specific question, but mental health has been mentioned as needing targeted support. If those people would like to email them the slide that I sent, then whilst that work is now happening, was very difficult the first wave. And it's very, I'm sure that the prioritisation, because that was done at a point, not perfect either, but we're now in a place where things that we may possibly missed first wave, we can pick up second. So very interested to hear more about that.
Yeah.
You want to contact us.
That would be really good, and I suppose that reflects what you were saying about fast, slow thinking. You know, the pandemic, you're just responding as quickly as you can, and not always doing everything as comprehensively or as actively engaged with partners as would be ideal. So it's using the capacity that we have to think about that. I've just noticed that while we've been on the webinar, there's a Health Service Journal have talked about COVID struck city, holding talks about cancelling ops in Liverpool, and that might affect cancer care. So, you know, that capacity we have to rethink and redesign is going to be compromised quite significantly by potentially some of the responses we have to make. Matthew, do you want to comment on that?
Yeah, I think that's such a key point. I don't know if anyone's seen the stat yet, but the people waiting more than a year is 100 times more than it was at the beginning of the pandemic. It just highlights the importance of not standing down anything this time if we can possibly avoid it. But the counter to that is that the size of the surge is really the deciding factor.
Yeah.
But it also demonstrates the length of recovery after all of this is another challenge that we need to start thinking about when we moment.
Yeah, and I was wondering, just to reflect on that in the kind of not standing down. It's something I mentioned very briefly in my introduction about the transparency of that discussion, where I was involved in a webinar recently where we were talking, one of our trustees, Maureen Baker, who is the ex-president of the RCGP, she said, we're in the space of rationing healthcare. This is where we are going to be, and we need to be able to prioritise and in order to get access to care to the people that really need it, and we need an open debate with our communities, the public and patients on that. And I wonder whether or not there's an appetite to do that in a very active way, because 100 times more, that's not normal range of how we do business around here. That's obviously a statement rather than the question, but anyway, the length of recovery, are you talking, Matthew, there about the long COVID patient groups?
I wasn't, but that's an issue as well. I was talking about catching up on all of the stuff that we haven't been able to do with patients because we stood so much down. And not even just that, I mean, you know, I'm not sure we got all of the messaging right anyway, but the reasons I've already mentioned, but some of the messaging led to increased anxiety in the population. I think that increased anxiety would have happened anyway. Getting people to come for our help is a challenge.
Yeah. And I'd like to come back to Paul. Probably we're going to have to finish in literally a minute. But Paul, I think when we talk about patient safety being a kind of systems issue needing to reflect, and you know, Matthew's summary of that describes the space that we all think patient safety should be looked at through a system perspective. Your insights from an industry point of view are invaluable. I mean, they've given us. I found your presentation and some of the challenges quite fascinating. How does that industry view inform what we're doing, or do we tend to, as a health and social care system, tend to just talk amongst ourselves? Do you feel that the industry perspective gets to contribute to some of that planning and feedback?
Definitely. I think sometimes it needs to go down a sort of a joint pathway with that procurement and sale of equipment. Is that, you know, the people that design and develop the equipment surely have the greatest insight into its application and how it's best used. And I think there needs to be a recognition that the speed of technology that's coming in, if it can actually potentially be detrimental to those levels of patient safety unless we work in partnership with the clinical staff delivering the care, and really empowering them to get the best out of it. You know, I could sell you a Porsche, but if I don't teach you how to drive it, I could probably beat you to the local supermarket in a Mini. You know, and it's that sort of concept that we need to change our thinking. And I think that the unique side I've seen from industry is that the looking in from the outside view that industry can have is really valuable. It's a drive for partnership, not a criticism, but we can see gaps perhaps where that internal focus doesn't see the gaps. And I think there has to be a much bigger partnership rather than a transactional relationship. You know, this is our product, you buy it. We have to move to a much more transformational relationship, and I think that's the way forward. I think it was already starting in the industry, but COVID-19 has really, it's opened up those little cracks into great big Grand Canyons that we can see that we have to address that, and we have to give more empowerment, more understanding to the clinicians and show them how they can change healthcare using the technology. Because otherwise technology is actually going to give us some, some problems just in itself.
And I see you nodding, Matthew, but that kind of feeds quite into your bottom left-hand quadrant around process engineering and the alignment of that with behaviours and knowledge management. So maybe we've made that direct connection there between Matthew and Paul. You can build on that. Final comments from each one of you, if I can leave you with that final comment there, Paul. But any quick kind of pointers or reflections on today's seminar from, I'll go Matthew, Cheryl, and then Claire. Oh, you're on mute, Matthew.
I'm not sure if it's a reflection or just a reiteration of the importance of. So I think we're very good at working out what needs to be done. I think something that we've missed and that hopefully teams like mine are starting to build on, I think that's one of the canyons, because behavioural insights really, its profile has risen a lot during the pandemic, is how do we help the people who are actually going to do it to see what it is they're being asked to do and do it without misinterpretation or all the things that we know the human mind does. We don't get the framing of the guidance, the infographic, or the whatever it is. I think that's the key thing that we need to move into in how my part of the system conveys its message to the front line.
Thank you. And Cheryl, final comment, reflection?
Yeah, thank you. I think what's demonstrated is how we're all working together to support our systems and the organisations and individuals within them to do the right thing during challenging times. And I think our real big challenge is, how do we mobilise our safety improvement programmes while still tackling the COVID pandemic? When everybody, all our stakeholders are so busy and engrossed in this work, it's difficult to move things on.
Mm-hmm. Thank you. Claire?
I think for me, I'm just watching the questions coming in on the chat, and I really seem to have opened discussion around the digital sort of online consultations, and there's some really useful suggestions and information being shared. So I think for me that's an area that we need to really concentrate on, particularly as it looks like we are heading into a second peak. So yeah, I'll be watching that discussion.
Great stuff. I'm gonna close it by well, a couple of comments. One, we often talk about health and social care being a safe system, and I think, you know, reiterating Cheryl's point about everyone working collaboratively for the same goal, and I think today's webinar emphasises that in the presentations, but also the chats. But I would very much support what you're saying, Matthew. That we know that we're beginning to know the what, that will still develop, but it's how we get that knowledge out there, how we apply it, how we learn from the application of it, and the feedback loop. And I think the kind of patient safety people that work in this area know very much about learning systems, about understanding from when things go wrong, getting that insight, but increasingly, if someone else is doing something really rather well elsewhere, making sure that information informs how they apply it, and we get that insight that comes from staff, but also from patients, so that we go from fast to slow learning, thorough learning that will improve safety. And of course, plug for patient safety learning. You know, we will do everything that we can to share that knowledge on through the hub, and we invite people to contribute to that. But the last two things, big thank yous to everyone that's contributed, the participants that have come up with some excellent comments and questions. I know there's been contact that will be made, emails being shared. We'll get all those resources out. Thank you so much for the panelists for your excellent presentations. Again, we'll share. But the biggest of thank you goes to Paul, because I think it was Paul and Rob from Gov.Connect and myself that coordinated to help shape this. And we had some fairly big ambitions for what the webinar could do, and I don't know, Paul, but from my point of view, I think that we set the bar high, and we've hit the bar. I'm very happy with the discussions that have been held, and maybe last comment from you, since you were part of the
I would agree. I think it's been a really good sharing of knowledge from lots of different perspectives, and my drive to sort of to push this is to get that message out there that the particularly in COVID, but generally with patient safety, we need to have a much greater dialogue ongoing to support those frontline people who, we may challenge them that their objective was to drain the swamp, but right at the moment they're up to their neck in alligators, and we need to reflect on that, and as a wider community provide that insight and support to make sure that patient safety does stay at the front when there's lots of firefighting going on. So yeah, I'm really, really pleased that conversation that Rob and I started off has come to this level, and that we've got that multidisciplinary message out there. So thank you to Rob and GovConnect for facilitating it.
Fantastic. Well, thank you all so very much. And, there's plenty for future webinars. We might see you again soon. Thank you very much. Okay, bye-bye.